and meta-analysis, there is new evidence that is emerging in airway management every single day. So if I lay down guidelines, maybe in a couple of months, couple of years, there will be new evidence to support something else. That is why a regular update of these guidelines is necessary. So this is what I meant by the AHA level of evidence and the strength of recommendation, that we have put level A evidence wherever we have more than one randomized control trial to support our research question or systematic analysis or meta-analysis or systematic reviews. Wherever there is a single randomized control trial, we label it as level B randomized control trial. Whenever there are non-randomized control trials, cohort studies, observational studies, we label them as level B NR. Wherever there is limited data, it is level C limited data. And wherever there is expert opinion, we have run it through a Delphi consensus paper. So this is the level of evidence based on the robustness of the available evidence that is there in terms of randomized control trials, systematic reviews, and meta-analysis. Then we come to the class strength of recommendation, where class 1 or strong recommendation means the benefit far outweighs the risk. Class 2A is where the benefit outweighs the risk significantly. Class 2B is weak, where the benefit is equivocal or slightly more than the risk. Class 3, no benefit, where benefit is equivocal. And class 3, harm, where the risk is more than the benefit. So this is based on the AHA table, which we have used to collate all the evidence and graded them according to this level of evidence and strength of recommendation. So that is the first difference. Okay, and accordingly, we have laid down these tables for recommendations and best practice statements. So I will take you through each of these statements at relevant places where we have put them in the algorithm. But in a nutshell, there are 5 best practice statements with the class of recommendation that is beneficial or equivocal based on the level of evidence. So I urge all of you who are logged in, and for the benefit of students also, to read the entire manuscript in its entirety, because there is a lot of tables that are mentioned as to what is the robustness of the evidence and wherever. So this is to collate, I have put it here, that it is a summary of the recommendations and best practice statements where literature was available. Coming to the next bit, wherever literature was sparse, we have used the Delphi methodology. So it should be used in conjunction with the methodology paper and the Delphi methodology paper. And we have these questions wherever we put these questions and we did not get answers in the form of randomized control trials or meta-analysis. We have run them through experts and tried to achieve consensus and made these consensus statements. So based on the number of attempts, based on what should be the emergency surgical airway, what should be the steps to optimize face mask ventilation. So this is just to summarize, and I will put each of these statements at relevant places where I have made certain claims during the course of my talk. The second difference that we had in these guidelines is that it is a collaborative effort by pediatric experts. Earlier, we had drafted the guidelines only based on representatives of different subpopulations who were AIDAA experts. For this particular guideline development, we involved the IAPA, that is the Indian Association of Pediatric Anesthesiologists, and they gave their representatives from their organizations who were senior people, who are experienced people, who are academicians and whose opinions mattered. So we had Dr. Anila Malde, Dr. Neerja Bhardwaj, and Dr. Sandhya Yadnapudi representing IAPA to help us draft these guidelines from the IAPA group. Similarly, we also did this for the Obstetric Anesthesia Society, and we had the Association of Obstetric Anesthesiologists who gave their inputs, and we collated these two societies so that we could lay down these guidelines with the best practice statements and with evidence. The third important difference is this is the 2016 algorithm, and this began with the premise that the primary airway management plan was always intubation. If you can see here, AIDAA 2016 guidelines for the management of unanticipated difficult tracheal intubation in pediatrics. Now, this began with the premise that your intubation was not successful, and then it moved down. Now, what has evolved is in the past 10 years, what has happened is more and more people have moved on to use second generation supraglottic devices, done cases on face mask only, or use apneic oxygenation techniques, use nasal cannula, or use TIVA or TCI with spontaneous breathing patients. So what happens to those patients in which the primary airway management plan was not intubation? Like I mentioned, all these other techniques. So in that, we did not have a because of the hierarchical design in 2016, we did not have a provision of moving from step 2 or step 3 onto step 1. So suppose your primary airway management plan was supraglottic airway device insertion or face mask ventilation, and that failed. Then based on hierarchy, you could move only downwards and not attempt an intubation. Okay, so there was no provision of going from step 2 or 3 to step 1. Now, if you see the current design, we have moved to a circular design with bidirectional arrows. So that means that if you are unsuccessful with one particular airway device, you have the provision of switching from that one device to another device, or a face mask, or a supraglottic airway device, or an endotracheal tube with video laryngoscopy or with direct laryngoscopy. So you can interchange between these devices so that your airway management plan is successful. If it is successful, you follow a certain path, and if it is unsuccessful, you follow the path. So another path. So in this, we have also coined a new terminology across all the guidelines, which is mentioned as code D. So when you raise a terminology, that code D means you are specific. It's like code blue. That code blue, how it deals with a patient who has undergone a cardiac, who has had a cardiac arrest, and it alerts the CPR team to reach the site for, and it specifically mentions that there is a patient with cardiac arrest. So similarly, when you raise an alarm for code D, that indicates that the patient, you're dealing with a difficult airway, and immediate assistance in the form of an airway expert and a difficult airway cart is needed. So you exactly know who is needed for this and what is the equipment that is expected to arrive with the person who comes with this. So that means that when you raise an alarm for code D, you exactly know what you are dealing with. So if you can see from the algorithm here, we have labeled it as AIDAA 2025 guidelines for the management of unanticipated difficult airway in pediatrics under general anesthesia. So it is not intubation centric. It could be any primary airway management plan. So these are the three significant differences. One is the robustness of the literature. Second is involvement by the IAPA. And third is the design algorithm that has completely changed. So coming to a disclaimer before I begin describing the guidelines, that these guidelines have been developed to help clinicians manage unanticipated difficult intubations in patients using evidence-based recommendations or Delphi consensus opinions from airway experts wherever evidence was lacking or weak. They do not represent the minimum standards of practice, nor are they a substitute for good clinical judgment. And the recommendations in the guidelines assume that the airway operator who is following these guidelines has adequate experience with the devices and techniques described here, and these are applied within the scope of their practice. Okay, so the person who is using or is recommended to be using these guidelines should be proficient in using this airway equipment. Again, the recommendations regarding the use of specific resources like devices, medications, workforce apply where these resources are available, and recommendations should be viewed as aspirational when this is not the case. If you don't have a capnograph, you should not say that the guidelines mentioned, but I don't have. So it is the duty of the clinician to get these devices in this era where there is no substitute to using shortcuts. So careful attention has been provided and paid to provide accurate and updated information. And the authors, however, acknowledge that literature related to the airway management is rapidly changing, altering our attitudes and clinical practice. Okay, so like I mentioned earlier, that there is new, if you see India alone, there is so many papers and literature that is available for airway management that it has changed the way we practice. So it is important to note that applications of these recommendations in specific settings remains the responsibility of the clinician. So this is just a disclaimer that we have put before each guideline, that they should be proficient in use, and the recommendations remains the sole responsibility of the clinician. Coming to the algorithm and the guidelines. So here we have mentioned the pre-oxygenation and induction of anesthesia primary airway management plans, which could involve either an intubation or a supraglottic airway device insertion or a face mask ventilation, nasal cannula, airway adjuncts alone or in combination during spontaneous or controlled ventilation. If this is successful, so if your primary airway management plan, whatever it may be, is successful, continue as planned. By successful, what I mean is you can maintain adequate oxygenation, okay, that is a saturation of more than 95%, and adequate ventilation, which is by a 6 square wave capnography breaths whenever it is feasible. Okay, so that is definition of success. If it is unsuccessful, which is defined as inability to insert an airway device or maintain oxygenation with respect to saturation more than 95%, or you can't adequately ventilate, which could be inadequate chest rise or no successful capnography. So we have taken an attempt to define successful primary airway management plan and unsuccessful primary airway management plan. So this is the first primary airway management plan. Coming to the vertical bars that come at the side of the entire algorithm, we have introduced a new term that is code D, which I mentioned earlier, highlighting that it is a difficult airway emergency. So call for help, highlighting code D. That means exactly you know whom to call and with what equipment. Call a pediatric expert. Define whom to call for help, preferably a pediatric airway expert. Depth of anesthesia should be maintained all throughout. Patient should not be aware if he's paralyzed. So maintain the depth of the anesthetic. Nasal apneic oxygenation should be continued. Okay. And the flow rate has been defined for pediatrics. Okay. So deliver oxygen at 1 to 2 liters per kilo per minute through a nasal cannula. So here we have statements that are described for apneic oxygenation, that we have: does apneic oxygenation increase the time to desaturation in pediatrics? So when we ran this research question, okay, we have high flow nasal oxygen or low flow nasal oxygen can be beneficial in increasing the time to desaturate in pediatric patients. This is a best practice statement because we found literature to support in the form of randomized controlled trials, and it was beneficial. So it is may be beneficial or can be beneficial. So that means you should always use apneic oxygenation to increase the time to desaturation in pediatrics. So this is the best practice statement. However, when we ran the literature search, we could not identify any literature to support what should be the oxygen flow rate, and that is why we ran it through a Delphi consensus statement. So what should be the oxygen flow rate used for apneic oxygenation during attempts at intubation in pediatric patients? So we designed that a nasal flow rate of 1 to 2 liters per kilo per minute should be the flow rate for oxygen in pediatric patients. And there was 92% consensus that we achieved. So 92% of the airway expert agreed to that the flow rate should be 1 to 2 liters per kilo per minute. So this is the statement for apneic oxygenation. Coming to the orange box, so this has a circular design with bidirectional arrows, like I mentioned earlier, that any device could be used without hierarchy. So it need not be intubation centric. It could be that you could have a supraglottic airway device in place as a primary airway management plan, and that has failed. So if your face mask ventilation, supraglottic device insertion, or endotracheal intubation has failed, you have the choice of interchanging between any of these three devices. Okay. So we've mentioned here, consider interchanging between these devices. Optimize the position for laryngoscopy, for supraglottic device insertion, or for face mask ventilation. Ensure adequate neuromuscular blockade. Consider changing the device, tools, or operator. Rule out laryngospasm as a cause for difficult mask ventilation, difficult supraglottic airway device insertion, and consider deflation of the stomach. So a nasogastric tube could be inserted if you are expecting that the diaphragm is moved up because of stomach insufflation and is causing splinting and reduction of FRC. This is particularly important in pediatrics. Again, limit the number of device attempts has been mentioned here. With tracheal intubation, it is 2+1. Supraglottic, I will mention this at relevant time points where I cover those particular airway device strategies. Supraglottic airway device is maximum of 2 attempts. face mask ventilation is not more than 3 failed attempts. And whenever you are doing the airway instrumentation, keep track of time and keep track of saturation. The saturation at all times during intubation and supraglottic airway device insertion should be more than 95% before a subsequent attempt at securing the airway. Okay, so this is the orange box. So how do you optimize face mask ventilation? Whenever face mask ventilation is attempted, maintain adequate depth of anesthesia, maintain patency of the upper airway while ensuring that the soft tissue is not being pushed. Okay. Head has to be maintained in neutral position. Use appropriately sized airway adjuncts in the form of oropharyngeal airways, nasopharyngeal airways if required. A ventilation with a two-person bag mask ventilation technique is beneficial. Consider lateral position of the child. Okay, so however, we did not achieve consensus for this lateral position. Identify and treat laryngospasm. Laryngospas itself is a problem. If there is laryngospasm, you will not be able to face mask ventilate a child. So you have to identify, treat it by giving propofol, muscle relaxant, short-acting muscle relaxant like succinyl choline, all of this. Relieve gastric distension with the nasogastric tube. If you are causing stomach insufflation because of laryngospasm, the diaphragm will move up because of stomach distension, and it will be difficult because of the basal atelectasis and because of splinting of the diaphragm. That is why relieve gastric distension with a nasogastric tube. Consider administration of a neuromuscular blocker and not more than 3 failed attempts at face mask ventilation. So this in a nutshell as to how to optimize face mask ventilation. We have written all of this in the main manuscript for those of who are interested in going through the main manuscript. Again, these are best practice statements and expert consensus statements. So does neuromuscular blockade improve face mask ventilation in children? Yes, there is a best practice statement because there are non-randomized controlled trials, but it is beneficial. So neuromuscular blockade may be considered to improve face mask ventilation in children. Okay, so there is literature to support this. That is why we have made this recommendation. Does two-handed face mask ventilation improve face mask ventilation? Again, there is a randomized control trials for this, and it is beneficial. That is why we have put a best practice statement. So two-handed bag mask ventilation technique may be considered to improve face mask ventilation in children. That means the person holding the mask will optimize the face mask holding, and another person will give adequate tidal volume ventilation with the reservoir bag. So this is claimed to be helpful. Coming to the expert consensus statement, wherever literature was lacking. So can administration of CPAP improve face mask ventilation when difficulty in face mask ventilation is encountered in pediatric patients? So like to say laryngospasm. The first strategy that you would do is give CPAP with 100% oxygen. So although we did not find literature to support this in the form of randomized control trials or non-randomized control trials, but there is 100% agreement. It is an teaching technique, right? So there is 100% consensus that we achieved that whenever you are having difficulty in face mask ventilation, CPAP with 100% oxygen is known to improve face mask ventilation in pediatric patients. So this is an expert consensus statement because there is no literature, but we have achieved 100% consensus. However, for lateral position, improving the quality of face mask ventilation in pediatric patients, there was no consensus achieved. Some people have found it extremely beneficial, but there was no consensus that was achieved amongst the experts. So out of the 3 interchangeable techniques, the face mask ventilation I have already discussed. Coming to the laryngoscopy and intubation. So there are a few prerequisites for laryngoscopy and intubation. Before attempting a laryngoscopy, always an IV access must be secured. Please do not attempt laryngoscopy in the absence of an IV access. Okay. Aiming to secure an endotracheal intubation without having an access can be disastrous. Appropriate monitoring, I don't need to emphasize that, but appropriate monitoring should always be available. Pre-oxygenation may be difficult given the fact that the child may be combative if you are trying an inhalational induction. But again, post-inhalational induction, securing the IV access before attempting the airway management plan, ensure that the saturation is okay and you are oxygenating with 100% oxygen with bag mask ventilation. Adequate depth of anesthesia, analgesia, and neuromuscular blockade needs to be maintained. Whenever nasal oxygenation can be given, please consider giving apneic oxygenation or nasal oxygen with nasal prongs or nasal catheters. And use of correct size equipment is a must. As you all know, pediatric airways are extremely delicate. The more the number of attempts, the more the airway edema, the more the difficulty and work of in oxygenating the child because of the airway edema, because of laryngeal edema, because of face mask difficulty, all of these. So use correct size equipment and have the minimum number of attempts and trauma in a pediatric airway. Again, how do you optimize laryngoscopy? So use appropriate size equipment, use the correct size laryngoscopy blade, ensure adequate neuromuscular blockade. Consider changing the device in the form of direct laryngoscopy, video laryngoscopy using either Miller's, Macintosh, or hyperangulated blades. Techniques like external laryngeal manipulation and bimanual laryngoscopy, which I will show in the next slide, are beneficial in pediatrics. The most experienced operator should be attempting the airway in case the first attempt has failed. Optimize the position of laryngoscopy. So if you're dealing with tinier children, a shoulder roll is helpful for laryngoscopy. Attempt only laryngoscopy attempt should be attempted if the saturation is more than 95%, which may not be possible in critically ill ICU children. Again, the correct size bougie stillets, which are mentioned in the main manuscript, should be used as intubation aids. Do not use inappropriate sizes, again, because the pediatric airway is extremely prone to trauma. Nasal apneic oxygenation, I have already mentioned earlier. Limit the number of attempts to 2+1. The third attempt should be done only if a pediatric airway expert is available. And this maximum number of attempts includes the first failed attempt, which may have been a part of the primary airway management plan. So like I moved earlier, you had a primary airway management plan earlier. If that had an intubation attempt, that should also be counted as an attempt. I don't need to emphasize this, but capnography is a gold standard for confirming success of endotracheal intubation, and it has to be used. There is no excuse to not using capnography. If you do not have a capnograph at an institute, please invest money and buy this. And 6 square wave capnograph breaths is mandatory to confirm successful endotracheal intubation. Now, this is what I was alluding to, the external laryngeal manipulation, that you use the little and the ring finger and the little finger to give external laryngeal manipulation. This is helpful even in slightly older children where you get the glottis into view. And this is bimanual laryngoscopy, where the person who is intubating or who's doing the laryngoscopy is getting the glottis into view. You can use this with a video laryngoscope as well. By looking at the screen, the person who is doing the laryngoscopy is giving the external laryngeal manipulation so that the glottis comes into view, and the second person is using the endotracheal tube and guiding it into the glottis. So this is two-person laryngoscopy or bimanual laryngoscopy, which is also known to be beneficial in children. Coming to the laryngoscopy statements about best practice and consensus statements. So does video laryngoscopy enhance the success rate of intubation compared to direct laryngoscopy in pediatric patients? Video laryngoscopy is not beneficial in success rate of intubation compared to direct laryngoscopy in pediatrics, despite improving the glottic view in children. Although it changes the CL grade from maybe grade 4 to a POGO score of 100% or CL grade of 2B, it does not necessarily translate into improving success rate, probably because it is evolving. The pediatric experts are still getting trained in video laryngoscopy, and some of them may not be proficient. That is why we found randomized control trials which compared video laryngoscopy with direct laryngoscopy in children. And we found that although it improved the glottic view, it did not significantly translate into improving the success rate of intubation. Okay, that is why it is mentioned here. Class 3, benefit more than risk. It is equivocal. Again, based on the maximum number of attempts, there are a lot of studies, the nectarine study, the apricot study, that with increasing number of attempts, there is a significant increase in trauma and airway edema. However, they have not put a number to it there are no randomized control trials to give a robustness of evidence. That is why we did a consensus statement by giving them this background that there are multicentric studies which have looked at what are the incidence of complications and the number of attempts. And they found that the maximum, we've laid down recommendations based on consensus statement that a maximum of 2 attempts with the third attempt should be done only by pediatric airway expert is the maximum number of attempts at tracheal intubation in pediatrics. Coming to the third part, the supraglottic airway device insertion. So AIDAA guidelines have recommended second generation supraglottic devices with gastric drain tube over the first generation devices across the board. People have phased out first generation supraglottic airway devices because of the reasons like improved oropharyngeal seal pressure, better fitting of the airway contour, and ability to pass a gastric drain tube through the upper esophageal sphincter and decompressing the stomach in case needed. The number of attempts at supraglottic airway device insertion should be limited to 2 based on the Delphi consensus statement. To enhance oxygenation, resume face mask ventilation between attempts. And if the first attempt at supraglottic airway device insertion is unsuccessful, the second attempt should ensure, consider changing the device or maybe the type of the supraglottic airway and the size before proceeding with the second attempt. So whether it is laryngoscopy, whether it is supraglottic airway device insertion, the second attempt should do something differently from the, don't repeat the first attempt because changing something is mandatory during the second attempt. Okay. So here again, we come to the consensus statement that what is the maximum number of attempts at supraglottic airway device insertion. So we came to a consensus of 87% that a maximum of 2 attempts at supraglottic airway device insertion should be done to minimize the incidence of airway complications in pediatric patients. So coming back to the orange box, that either you could give 2 + 1 attempts at tracheal intubation with a direct laryngoscope or a video laryngoscope, with devising, changing the device technique or operator between each subsequent attempt. The bag mask ventilation has to be resumed so that the saturation is more than 95%. 2 attempts at supraglottic airway device insertion with a second generation supraglottic airway device, or a maximum of 3 failed attempts at face mask ventilation, keeping track of time. Preferably, the most experienced operator should be attempting the airway management technique, and all these attempts should be including the first failed attempt of the primary airway management plan. Coming to after any of these techniques becoming successful, which could be having success means having 6 successful capnography breaths. So endotracheal intubation has to be confirmed with capnography. However, with face mask ventilation and supraglottic airway device, you have the option of either waking up the patient and planning a different airway management strategy, or continue the procedure with the face mask ventilation or supraglottic airway device insertion if it is considered safe to proceed with the anesthetic. If you have a supraglottic airway device insertion, blind intubation through the supraglottic airway device is discouraged. Use a flexible video endoscope, provided you have the correct size equipment and correct expert available to do that, and tracheostomy to be done only if the surgical expertise is available and the surgical technique is demanding. Suppose you are doing a head, face, neck surgery where there is major reconstruction, only then you are justified in doing a tracheostomy, because pediatric tracheostomies are fraught with dangers, and they are to be done only when you have pediatric experienced people who are proficient in doing pediatric tracheostomies. Coming to the emergency surgical airway and complete ventilation failure. So complete ventilation failure is a strategy that was defined in the previous guideline in 2016 as well, and we have continued that terminology. So when you are unable to secure the airway by non-invasive techniques, that is by using an endotracheal tube, by using a supraglottic airway device or a face mask ventilation, despite the best efforts after using a neuromuscular blockade, you declare complete ventilation failure. So this is the CVF terminology that we have adhered to in all the guidelines, and we have carried that forward from the 2016 guidelines. We have asked to call for additional help here, And this additional help is a pediatric airway expert who can deal with a surgical airway. The best trained person, either a pediatric surgeon or a pediatric ENT specialist or an anesthesiologist, who can deal with this pediatric complete ventilation failure scenario. And when you are dealing with this, continue efforts to rescue face mask ventilation and oxygenation through the upper airway. Again, this is a very nice pictorial that we have mentioned here, that emergency surgical airway, whenever trained surgical help is available, a tracheostomy at the level of the tracheal cartilages should be recommended. However, when a pediatric surgeon or a pediatric expert at doing a tracheostomy is not available, then when the child is less than 5 years of age, you do a cricotracheal puncture. That is at the level of cricoid cartilage and the tracheal cartilage lower down, because the cricoid cartilage is much higher up because of the adipose tissue, because of the short neck, because of the cricoid pressure being higher up. It is difficult to palpate the cricothyroid membrane in children less than 5 years. So you move slightly lower at the level of the cricoid and the tracheal rings and do either a cricotracheal puncture or a transtracheal puncture. However, in older children, the cricoid cartilage moves and the tracheal cartilage, the thyroid cartilage moves down and the cricothyroid membrane is easily palpable. That is why you do a cricotracheal needle puncture and you use a jet ventilation device. Okay, so this is a nice pictorial that is available in the manuscript. So whenever you are doing a tracheostomy, we have come to a conclusion that the scalpel bougie tracheostomy, that means that the person who is doing the tracheostomy will insert a bougie into the trachea, and a tracheostomy tube or an endotracheal tube will be slid over this bougie so that it does not go in a false passage. There are multiple mannequin studies and animal studies that have recommended that a scalpel bougie tracheostomy is beneficial over a conventional dilator tracheostomy and putting the tracheostomy tube using a dilator, because a bougie is smaller and the success rate of railroading a tracheostomy tube over a bougie is found to be much more successful. So proceed with this emergency surgical airway by keeping the upper airway patent, by attempting oxygenation through the upper airway, by giving apneic oxygenation through the upper airway, and begin with emergency surgical airway before the child begins to desaturate. So tracheostomy is recommended by using scalpel bougie technique and railroading a tracheal tube over a bougie. However, if surgical help is not available and you are doing either a cricotracheal or a cricothyroid puncture, you use some of these non-kinkable cannulae. Make sure that it is in correct space and use a jet ventilation device. Again, Ventrain is a new device or Rapid O2 is a new device. However, literature is not very freely available with these new devices. That is why we don't have recommendations with any of these devices. And all of these studies are done in animals or mannequin studies and extrapolated to children. Whenever the needle is in trachea, begin with the lowest possible pressure of 0.5 bar and gradually increase to avoid barotrauma till you see a visible chest rise and improvement in oxygenation. Maintain upper airway patency with face masks so that there is adequate time for expiration of 1:4. So 1 second for inspiration, 4 seconds for expiration. Otherwise, you could deal with barotrauma, pneumothorax, and all of these problems. That is why maintain patency of the upper airway, begin with the lowest pressure, and give enough time for expiration to occur with the upper airway. Oxygenation must be considered through the upper airway. The I ratio, 1 second inspiration through the jet ventilation, 4 seconds expiration through the upper airway to avoid barotrauma. Cannula kinking, dislodgement should be avoided. And whenever you are doing the cannula cricotracheal puncture or cricothyroid puncture, a surgical tracheostomy has to replace that as soon as possible in less than 40 minutes to prevent hypoxic injury or dangerous hypercapnia in children. So this is enough time to call somebody in the hospital and do a conventional tracheostomy with a scalpel bougie tracheostomy technique. So again, here best practice statements. So whenever is tracheostomy the preferred technique for emergency surgical airway in children when trained surgical help is available? There is limited data to suggest this, but it is beneficial and there is a best practice statement. That is why we've laid down that whenever experienced surgical help in the form of a pediatric ENT or a pediatric surgical expert is available, tracheostomy should be the preferred technique with a scalpel bougie tracheostomy technique. Again, For the cricotracheal puncture in children less than 5 years, a cricotracheal puncture, we have achieved 100% consensus because we ran it through a Delphi statement, and we have achieved consensus that a cricotracheal puncture is the technique of choice in children less than 5 years. And in children between 5 and 12 years, the cricothyroid puncture is 100% consensus that we have achieved. Okay, because there is no data to support in the form of robust literature in any of these scenarios, fortunately, because it's a relatively rare phenomenon. Coming to the post-procedure plan, further airway management plan should be chalked out. So if you're waking the child up, or if you're continuing the case, or if there are multiple attempts that have been taken and you have been able to secure the airway and oxygenation, you wake up the child. But again, because of multiple attempts, there could be airway edema, there could be crew. So nebulization with racemic epinephrine and all of that. So further airway management plan needs to be chalked, and airway edema needs to be treated. Monitor for complications, and counseling and documentation of the parents that you had dealt with a difficult airway, and subsequent attempts at airway instrumentation needs to be flagged and kept in mind for subsequent attempts. Again, these are the QR codes for those interested. You could take a screenshot and scan these QR codes for the full text of the manuscript, as well as all the robust literature, the tables, the Prisma statements, and all of the literature that we have collated and put into these guidelines as an appendix. So all of this is freely available for download for all of those manuscripts that I mentioned earlier. And this is the methodology paper. This is the at-risk extubation guidelines, the difficult airway cart, and the Delphi paper. For all of those people who are interested, you can just scan the QR code and it will directly take you to the link for the full text of all these guidelines, which were published in the November 2025 issue of the Indian Journal of Anesthesia. Thank you so much. And we are open for questions.
Thank you, Dr. Jason, for this. Yeah. Yes, ma'am. So that is how we start. So first we'll have comments from chairperson. Okay, madam, Burusali, madam.
Oh, the chairperson did not wait enough because she was just too excited to share what she felt while she heard Jason.
No. Yeah, no, madam. Please go ahead.
Yeah, thanks. Jason, a few points that I noted when I heard your thoughts very carefully. The bilateral flow that you have, I mean, the circular bilateral flow that you have said, I think is so logical and pragmatic. It's very appealing, I must say. I always thought it should be so. However, I'm not too sure. Whenever I read guidelines for airway, something that is so crucial during our day-to-day work, the gastric insufflation that happens when we go for mask ventilation in that, and it seriously jeopardizes ventilation. I'm not too sure at no point why no airway guidelines really look into that keep an infant feeding tube ready and deflate the stomach. Because I have seen children having difficulty in ventilation at times because of that, more often than not. That was my second thought. The third thought is, how will you tell that code D is this, and how will everybody know in the hospital?
Can I answer that right away? So there is a separate paper in the same issue of the Indian Journal of Anesthesia, which alludes to what is code D, when exactly should you call for code D, and what are the things equipment that should be kept ready. How do you formulate an airway alert card? What are the things that you should give the patient? So there's an entire manuscript and a paper for that. But as an airway lead of a particular hospital or an academic department, it is the duty of the clinician who is the airway lead to bring about awareness amongst their colleagues to actually raise this, like how we take a conscious effort to have the code blue and announce on the loudspeaker. So when it comes along with a code blue, people are not sure as to what you are dealing with, whether it is if you see children, majority of the times, the cardiac arrests in children are respiratory arrests because of drowning, because of poor oxygenation, all of that. So when you raise an alarm of code D, the person exactly knows that you are dealing with a syndromic child, with a difficult airway, with an oxygenation problem. So the person who is likely to be expected to reach there as soon as possible is probably an pediatric anesthesiologist or a pediatric person who is equipped to deal with a difficult airway and has the correct gadgets and equipment, so that they are not waiting for equipment to arrive or waiting for the required person to arrive. So the senior most faculty who is trained in pediatric airway should be ideally mobilized to that area where the problem has happened. And that is why it creates a sense of urgency as to what you are dealing with and why that person and why that equipment has to be moved to that particular site. That is why this particular code, so that people are aware that who is needed, where they are needed, and what is the level of experience, expertise, and equipment that is needed at that site.
Okay. And Jason, about deflate stomach, I think you can comment. It is already there.
Yeah, it is there in the guidelines. So,
okay, Jason.
Yes, Dr.
Jason, just a point here, as Madam asked a very important question about Code D. So the earlier versions and other guidelines says call for help. So when you are managing inside the operating room, maybe so many factors, we do not know what call for help means. So that's why D stands for difficult airway. So to make it more specific, Code D activation is required, so that when we say pediatric anesthesiologist or the expert help are required, so people know that a specific help is required rather than in general call for help inside the operating room. So that's the reason Code D is being used, proposed by AIDAA in various guidelines to streamline the call for help. And secondly, when Madam asked about the use of the other adjuncts, so each of the guidelines has talked about using the adjuncts. And you very rightly mentioned very important point that the gastric insufflation jeopardizes the ventilation and oxygenation. So when we say adjuncts, it is a part of those adjuncts, but yes, we can specify more subsequently. But those adjuncts may also be considered in case if we are having some difficulty in ventilating this child during the airway management. So these are all clubbed together in those adjuncts. Yeah, thank you.
If I may take that,
Sir,
if you see the orange box in the AIDAA, the only guideline where this nasogastric tube insertion and decompression of the stomach is mentioned is the pediatric guideline, because it is a problem that is so unique to pediatrics. If you see all the adult obstetric guidelines, nowhere has the nasogastric tube insertion being and identification of laryngospasm being spelled out so distinctly in the main algorithm itself.
Yes.
So that is very unique to pediatrics. That is why we have brought it out in the orange box that is there.
No, I was searching that. My eyes did not see. That's why I asked you, Jason.
Correct. Yes, ma'am.
Yes. So now another thing is, I saw your slide very carefully about declare complete ventilation failure.
Correct.
Would it have benefited to say, but continue para-oxygenation?
So if you see on the left-hand side, no, madam, there is an apneic oxygenation technique, which the, do you want me to share the slides again? I can do that.
Jason, I can share the algorithm part if you want. I can immediately share the algorithm.
Please do that.
Yeah, we can show that exactly where it is. Okay.
On the left-hand side of the entire algorithm, we have stressed on three things. One is call for help, that is expert help. Second is maintain the depth of the anesthetic. And third is maintain oxygenation at all times, even when you are attempting to do an airway instrumentation. So that is apneic oxygenation with the oxygen flow rate, which is mentioned. So on the left-hand side, those three vertical bars that are there through the entire algorithm, no, all these, the red, blue, and black.
Okay. Lovely. All right. Jason, yes.
And this is about, madam, deflation of the stomach if inflated, in the center. Yeah, it is there inside the algorithm part.
Done. What about role of ultrasound here? And any study done on that? No, I did not see a research question there.
Correct. So there's not too much robust evidence that is there on the ultrasound. The only thing that is there is they've identified the cricothyroid membrane or something like that in children, but evidence is still evolving. So in the disclaimer, I mentioned that as we evolve and get more and more literature, ultrasound, again, I'm sure that there are a lot of studies that are coming up in identification of the cricothyroid membrane, in correct positioning of the supraglottic device with ultrasound, with respect to predictors of difficult laryngoscopy, predictors of difficult intubation. But a lot of the literature that we have got is adult based. Like if you see the tongue thickness, if you see the skin to epiglottis distance, all of that is for adults. There's not too much evidence that is coming out for pediatrics. So I think in the years to come, we would be having that literature, which would change some recommendations here, I feel.
Sure.
Can I comment here,
madam,
if you don't mind? When it comes to ultrasound, where I have found help is whenever our ENT doctors are doing tracheostomy in neonates and small children, they in fact ask us to mark on ultrasound the thyroid, the cricoid, and the tracheal rings. So after we position, we quickly scan, and with a marker, we put those marks, which makes it easier for them. So if my suggestion is, if we routinely practice ultrasound of the airway, just the, if not everything, just the cricoid, thyroid, and the tracheal rings, which is not very difficult. If we do it routinely in probably an anticipated difficult airway, it will definitely come handy. At least we'll be better off with the anatomy, just in case a surgical airway is required. As we all agree, surgical tracheostomy or cricothyrotomy is difficult in children. So it's better to be better prepared, I thought.
Sure, madam. Sure, definitely.
Thank you. Thank you.
Can I speak, sir?
Yes, Jayanti, madam, please.
Yes,
Yeah.
Jayanti.
So actually, I heard Dr. Jason sometime back, and we've been a great fan of the guidelines because we found that one situation where it makes a tremendous difference to continue oxygenation by some way, at least with the nasal prongs, is when we are doing procedures under tubeless anesthesia, where it's the airway procedures. And before, we used to we were doing it, but then this guideline and this reinforcement forced us to put in endotracheal tubes in the nose as a nasal airway and to continue the oxygenation. So that period, that little desaturation which we used to get before has completely gone. So now it's becoming a practice. Even actually, I think in a lot of centers abroad, they use it for conventional intubations as well, especially if their postgraduates are doing it, to put in a nasal prongs. But we definitely use the prongs or oxygenate during the process of intubation, which was not the case before in difficult situations.
Correct.
And then, especially in tubeless, when we're doing tubeless techniques, when either the surgeon is introducing the scope, or there's some situation where you have to take off the mask and you don't have any other device. So that's made a difference. The other thing I noticed was there was a mention in the text that you place a roll under the shoulder in smaller infants. So
Yes.
that makes a lot of difference. I think the pediatric guidelines, I mean, the PALS and other texts talk about keeping a roll under the shoulder. I think less than 2 years, or at least less than 6 months.
Yes, ma'am.
Yeah.
That is mentioned in the manuscript, and I
Yeah.
have also highlighted that during the laryngoscopy bit and all of that. So that is mentioned. So earlier we found that neonates as a separate population. And these guidelines, we have emphasized that we are dealing with airways of between 1 and 12 years of age.
Okay.
So we've not included some of the neonatal consent guidelines, and the neonatal guidelines have actually internationally come out by, I think, Dr. Disma et al. So we did not want to just reduplicate that same literature search and all that. That's why we've come out with pediatric guidelines, but neonate is a separate subset population. So we've not dealt with that. But again, younger children who are maybe a year or 2 years old, that shoulder roll definitely helps, and that is why it has been mentioned in the manuscript. Yes, definitely worth considering.
And
Thank
in the
you.
guideline algorithm, this covers under this optimizing position part.
Yes, I saw it.
Yeah. Okay. Bala Bhaskar sir,
Yeah,
any
yeah.
comment, queries, or
Yeah. I have. May I come in, please? Amit?
Yes, sir. Yes, sir.
Okay, nice. First of all, congratulations that it was a very good presentation by Jason. So nicely taken forward and described in terms of the pediatric part. As he says, some of the points have been covered in the adult publication, so that there is no repetition in terms of some of the basic concepts, I think. But what we should be, I think, probably conveying to many of the trainees who are also attending today is pediatric airway can be by default considered as a difficult airway itself. Not like an unanticipated or anticipated difficult airway or electively a patient who has got a very good airway. I think every airway in a pediatric patient, especially in the younger age group, would be a difficult airway. So that's the one statement which we can always make. And secondly, there is no scope for any experimentation and lack of preparation. So when we have the advice on the first attempt and the second attempt, or the first two attempts and the last attempt, I think the first attempt ideally shall be the best attempt. When we think about the pediatric airway management, rather than telling that I again prepare better for the second one, or I call a well-trained pediatric anesthesiologist the second time and all. So that's another take-home message when we have to convey to our youngsters, basically. But overall, because these are, I understand, because these are basically guidelines, and they are all have to be based upon a lot of evidences. And some of the opinions are expert-based Delphi consensus-based statements have also been provided. I just heard about the no desat technique and administration of oxygen as a para-oxygenation and other things. What I also felt was this so-called peri-intubation oxygenation. Are there evidences to probably say that this will be a standard approach in pediatric airway management, rather than, when we compare to adults, that this shall be a standard? Because I had Dr. Rocky's opinion and Dr. Jayanti's opinion, as well as Madam's opinion. Probably, if evidences do allow us, permit us to give that statement, it can be taken up as a standard approach in pediatric airway management.
Yes, sir. So
highlighted, specifically highlighted.
Yes, sir.
Is it not?
So there is evidence to suggest that apneic oxygenation is better. So if you, in the slides, I mentioned a statement that there's a best practice statement that apneic oxygenation is beneficial.
Yeah.
And there are randomized control trials to suggest the same. However, the flow rate is not, we don't have a robust evidence to suggest what should be the flow rate. There are very scarce studies. So that is the flow rate has been recommended by going through a Delphi, because different studies have shown that apneic oxygenation is beneficial, but they have used different flow rates. Somebody has used liters per kilo. Somebody has used fixed flow rate. So we don't have definite evidence to suggest that. There is one study by Humphrey et al. From British Journal of Anesthesia where they have compared 100% oxygen of 0.2 liters per kilo, then 2 liters per kilo, and then 30 liters of just plain in a high flow coming down on the FiO2. So they have found that 100% FiO2 is beneficial and just increases the apnea time. That's why we have made those recommendations. And wherever the flow rate was lacking, we have run it through a Delphi and put that Delphi statement of 1 to 2 liters per kilo per minute should be the flow rate.
Yeah, but in the relevant area,
correct,
in the table and in the text, actually, what I saw was there was probably 1 to 2 liters per kg per minute. Probably in the bracket, within the brackets, we had the high flow nasal oxygenation.
Yes, sir.
But no, basically high flow nasal oxygenation, of course, its availability is one aspect across the various setups. And I thought a altered statement or a statement before we speak about this, like a nasal prongs or cannula oxygen flow as per the individual patient.
Correct.
Could have been a better statement.
So the advantage here is, sir, in pediatrics, you are dealing with 8, 10 kilos, 15 kilos children. So you don't need a OptiFlow or an Airvo or a Fisher and Paykel machine that is available. Just the auxiliary meter that is attached to your anesthesia workstation, that will give you 12 liters to 15 liters of oxygen flow. So if you have humidified flow meter through the auxiliary port, you can give 10 to 15 liters of oxygen through that auxiliary port in addition to the face mask ventilation that you are attempting. So you don't need the high frequency nasal cannula specific machine. In children, unlike in adults where you need to give 50, 70 liters flow, in children 10, 15 liters, 20 liters flow, you can give through the auxiliary oxygen flow meter also.
No, that's perfect. No, my observation only was
yes,
no, your explanation is perfect. My observation was in terms of the typed material.
Yes, sir.
What has been there in the publication. So
sure.
I think sir's,
that's there.
I think sir's point is very important. We can always little explore and clarify into our presentations. Probably the terminology of HFNO and AVO2 have been used in adults, and that's why they talk about 16 liters. But using 10 liters for a pediatric is again a high flow actually. So probably we need to define more clearly. And sir, your point is well taken. Maybe in some way we will put it very clearly into our guidelines presentation that this may also be considered as a high flow for a small kid of 5 to 10 kg, where we are using say 5 to 10 liters, probably will be high flow. So this will be take up into the guidelines. And a very important point, sir. Thank you, sir.
That's what I just wanted to convey. There were some smaller things which I probably Dr. Jason to just explain to the PGs here. Like I probably thought some explanation would be as part of a take home. For example, there is a mention of the succinylcholine dosing as 1 to 2 milligram per kg for laryngospasm. Would you? No, I don't have objection in the sense I can understand the rationale and the background of this 1 to 2 mg per kg. But as per the evidences, would you say that it can be anything above 0.25 or 0.5 milligram per kg, or you want to justify that I really want a perfect relaxation with succinylcholine for laryngospasm because it's more dangerous in the pediatric age group?
Yes, sir. So if in the bag mask ventilation in the management of laryngospasm aspect, no, I have put apart from the face mask ventilation, what are the ways to improve face mask ventilation? The methods to deal with laryngospasm as far as CPAP, 100% oxygen, propofol, or IV induction agent to relieve the laryngospasm, and then succinylcholine as a last resort. So that is mentioned, and we can definitely make it crisper in. So I did not want to pack too many things into the presentation, so I have not gone into the doses and all those details because then that gets...
Yeah, understandable.
Yeah. Can I say something? I'm Dr. Naigude.
Yes, madam.
Yeah.
Yes, madam.
See, I have found stellate a very, very important instrument for directing the tube, particularly in infants, because the tube, these Portex tubes are that way soft, and they, as soon as you butt around the larynx, it gets bent. So with the stellate, you can easily direct it to the larynx, and particularly with coma, stage 3. And another thing which I wanted to say, some of the patients I have found that I could ventilate them in a better in a lateral position, and I could in fact intubate them also. One was of course bleeding tonsils, post tonsillectomy bleeding. Another was a small polypoid growth in a neonate. The baby could not sleep in the prone supine position because it was obstructing the larynx. So the baby was nursed in the actually prone position. In that case, I had to do the ventilation, spontaneous respiration, and everything in the lateral position, and intubate also in the lateral position. A third case is Treacher-Collins syndrome. That time we didn't have FOB. So that patient also with topicalization of airway and everything, our routine measures in the beginning, I could not ventilate in the supine position. When I turned him to the lateral position, I could ventilate him better. And in fact, I could intubate also. So, I mean, I wanted to say these 2 things. The Stillate comes very handy. You can direct the tube, and now you get very good stillates which are not traumatic, and you don't have to go, beyond the tube, end of the tube. So you can direct the tube very well. And lateral position also, I think everyone should know how to intubate in lateral position also.
Yes, madam. That is why in the manuscript, we have actually given recommendations for what type of stillet should you use. It should not project beyond the tube. What type of bougie should you use? So it's there in the main manuscript. I have not put pictures of those because I did not want to sound my presentation that I'm propagating a particular brand or something like that. So that's one of the things. Second, lateral position, yes, we have addressed, although we did not find any literature in to support our evidence. That's why we've run it through a Delphi consensus. And again, we could not achieve consensus even for the lateral position. I personally find it beneficial, and that's the reason we put it. But some people were not okay with recommending it as a consensus agreement for giving lateral position.
One more case, a huge hydrocephalus. It was not possible to extend it in the supine position. In the lateral position, I could, of course, nowadays you don't get such huge hydrocephalus because they are already diagnosed and then.
Correct.
Yeah, okay.
Actually,
all of these.
It was a nice presentation, Jason.
Yes.
It was very
Thank you,
nice.
ma'am. Thank you.
Jason, I must say your unanticipated airway guideline is fine-combed here. Absolutely. Daigode madam, very nice to hear your voice. Just one last point. In one of your slides, you said IV is a must in unanticipated difficult intubation. And we are also talking of laryngospasm. So of that storm we pediatric anesthesiologists always face. Not always, but yeah, that storm is possible. We're doing an inhalational induction so that we can take an IV under the inhalational induction, and then we have a spasm. So now it becomes an unanticipated, seriously unanticipated difficult airway. Now we go to probably scoline, which is IM, and then that dose is different. So would you have considered that?
So in the slide, if you noticed it, I have put IV access is a must when attempting laryngoscopy. It's not for general testing. So I understand that most of the cases we are doing under inhalational induction, and that's the art and beauty of pediatric anesthesiologists, that you have to realize when is the patient sufficiently deep to give a patient painful stimulus with a cannula, so that the child does not go into a laryngospasm.
Yes.
So that is the most important part. And if you are expecting a difficult airway, so it's there in one of my other presentations that in anticipated difficult airways, do not hesitate in, even if the child cries, in putting EMLA cream and securing the IV access awake. So don't deal with two problems simultaneously, problems of a difficult IV access and problem with a difficult airway. So if you anticipate a difficult airway, please make sure that you have an IV access awake, putting EMLA cream in with the parental presence and using distraction techniques. If you're dealing with an unanticipated difficult airway, take the child adequately under with inhalational induction and then give a painful stimulus. But definitely, if you're doing a laryngoscopy, make sure that the IV access is in situ because the vagal tone is very strong and you don't want to deal with bradycardia and all those problems when you are attempting a laryngoscopy. So these are the two or three different things that I wanted to point out.
Here, Dr. Jason, I seem to be noting the same points that as Dr. Vishali. So I thought when you said intubation, you must have an IV. Obviously, you must have an IV. But sometimes I've seen when we are planning a supraglottic, which we plan for a lot of routine cases these days. So, the IV is getting difficult or it's taking time. A lot of times we put the supraglottic first so that the gastric inflation is not there because you're putting second generation and you're putting a suction tube. So, at least the ventilation is better than a face mask. Of course, with the inhalational, the depth should be adequate. And then you can take an IV without panicking.
Absolutely. So for supraglottic device insertion, it is not mandatory to have an IV access because you don't want to deal with a difficult mask ventilation and struggle with an IV. Because if your mask holding is not proper, the child will not be adequately deep and you will give a painful stimulus and cause a laryngospasm. So for supraglottic device insertion, it is not mandatory to go ahead with an IV. I often do that I put a supraglottic airway device. I maintain the depth of the anesthetic with the supraglottic airway device, have the bag close to me so that I can see that the patient is taking adequate tidal volume, and then give a painful stimulus for the IV cannulation. So for that is okay, but definitely laryngoscopy, I wanted to convey that message to all the trainees here and whoever is dealing with pediatrics, that laryngoscopy is a strict no-no unless you have an IV access in place. You go ahead with a supraglottic airway device, secure the IV access, and if intubation is required, you give a muscle relaxant and then go ahead with a laryngoscopy so that things are sorted.
Just one thing I wanted to suggest, because
Yes,
I have
ma'am.
read one paper, Dr. Daigude,
Yes, ma'am.
because you are not able to take the IV beforehand, and you don't want to have the painful prick, during inhalation or induction, because that can itself cause laryngospasm. There was a paper, because this Embla cream takes 45 minutes to act.
Correct.
You can use the 10% lignocaine spray. Just give one lignocaine spray, and another, after 5 minutes, another one, and you get you can give a painless venipuncture.
It's a fantastic choice, madam, but unfortunately, even
I mean,
if
nobody is
we want to
using
do
it.
that-
I have read that paper. I mean, in fact, I have reviewed that paper. That's why I'm...
It's a take-home message you can give people, provided it's not too evidence-centric, because my ethics committee will never give me permission to use an off-label indication for a laryngeal spray to spray it on the skin. They're saying, are you justified to using this? Because this is not the proposed route of administration of this drug. So I'm not very sure whether evidence can emerge out of it.
It is allowed orally,
For
oral
skin,
spray.
I'm not very sure how is the absorption and how is the action. So I don't think it was designed for that particular indication. So ethics will always stick to that and say, okay, this is an off-label indication of using an altered route of administration of that drug. Are you justified in using it? So if you're not too focused on getting literature and data.
This paper was actually published in our AIDAA.
Correct.
A few years back, I had reviewed that paper, and I found it very
it works,
helpful.
As long as you don't exceed the
think
toxic dose. I think somebody has mentioned here that
sometimes what happens, simple things we don't use.
Correct.
It is, I think, one of those things.
Correct.
Ma'am, just to comment upon, when we make guidelines, we have to use the drugs techniques which are approved by the authorities. In the guidelines, we may not put any drug which is off-label used as a part of guidelines. But yes, anecdotal experiences and publications do come up, and they do require a specific approval from the ethical committee. So in guidelines, we were a little cautious to use evidence and Delphis. But your point, I think, when we talk about anesthesia practice, many things which we are using off-label, and we have seen its much more beneficial effect. So I'm sure that those who are listening to today's webinar, they will take it forward. They will get more evidence and look for how those sprays can transdermal absorption, which can be used very beneficially for these patients. People have used even the lignocaine jelly, not the amla cream. How the jelly get absorbed, again, a matter of concern. But then we have to look for how these things can come into picture. But being guidelines, we were cautious not to put those things which are off-label use, because that will create issues for the applicability of guidelines. And your points are well taken. I think
the guidelines, but it's a practical use.
Yes, I agree, ma'am. I think off-label, coming from you and an expert, people will be using it off-label use, but they should be cautiously as far as the concerns are considered.
Of course, the dosage should be considered in case.
Yeah, absolutely, ma'am. Absolutely. We have Dr. Jayanti also as chairperson. May I request madam to put some comments and her experience with regards to guidelines, or if any queries? Jayanti, ma'am.
Sir, I did mention something. Maybe you missed.
Yeah.
So
I saw there. That's why I want to just explore your experience. People feel comfortable.
So somebody's asked about using 10% lignocaine. So we find that using 1 to 2% lignocaine is sufficient as a local anesthetic spray for airway procedures, spraying the larynx. You don't necessarily need the 4% or the 10%, just to clarify the query by somebody who's asked. Besides that, I think I did raise a couple of points, and I liked Dr. Jason's explanation of the whole thing, because it's quite exhaustive, and I think as postgraduates should read the article a few times to imbibe its contents. One contention I have for postgraduates is I'm not very sure I'll be happy for them to put a laryngeal mask airway when they're trying to find an IV if they're not very experienced, because it gives that extra chance that there can be a laryngospasm. We still ask our fellows only to hold a mask or to try the IV awake when we are not around, because children can act funny and they're not sure whether, I don't know, maybe that's just
it's really dangerous.
I'm being cautious, but I have worked abroad where they regularly do it. So it's just that it's each individual. Thank you, sir.
Thank you, ma'am. Thank you so much. I think many of the questions has been taken care of. If anybody has more, they can unmute themselves and then ask directly from either the chairperson or the speaker. All experts are there with us. So feel free to talk to them, and you can call or share your experience, or else we will proceed with our Kahoot-based quiz and see how much we have learned and get more exciting prizes there.
Thank you.
Rakesh, am I audible?
Yeah, audible, sir. Audible, sir.
There is some internet issues, but just on final statement, just I wanted to convey, we have some specific factors which contribute to a physiologically difficult airway in pediatric, quite separate from what we encounter in the adults, right? The physiologically difficult airway. So and we also were discussing about the code D. Even the code D preparation and the components of the code D cart or the cart would be actually slightly different. I was just thinking in mind that why would not it be a code D plus? Because there is an extra urgency when we speak about the pediatric difficult airway management. Yeah, especially when we speak about the more younger age group, just around the infancy, 1 year to 2 years to 3 years. We have some additional or physiological factors which are more dangerous as compared to the adults. So the code D would be probably code D plus in a pediatric situation. That will be one thing which we can always highlight. As we were discussing, it's never advisable to take a risk in a pediatric population. Even we are discussing about the front of neck access, where we have difficulty in cricothyroid access. We think about tracheal approach, area, so to be approached. So keeping these factors in mind, that's the reason I was also nodding my head when Dr. Jayanti was speaking about the supraglottic airways. We, as experienced anesthesiologists, will have some confidence in putting the supraglottic airway the first attempt itself and perfectly sitting. But I would never advise younger doctors also. Younger consultants, forget the postgraduates. Nobody shall attempt even a supraglottic airway placement without an IV line, because that can still precipitate a laryngospasm, that can still precipitate some regurgitation, because we are talking about some sort of IPPB creating gastric dilatation and risk of regurgitation. So probably in our setup, based on our experience, we may have some decisions to make. But younger anesthesiologists and postgraduate trainees, ideally they should be sticking to the more basic component of management, like having an IV line and then going ahead with the supraglottic airway insertion. Thank you.
Yeah, absolutely. I think all your points are absolutely very important. That's why the AIDAA was aware of it, and a separate manuscript was published, which included code D, difficult airway cart, and alert form. And we had a separate algorithm. And you're absolutely right. We do discuss, and I'm sure that in coming sessions, we will try to propose how these code D can be individualized for obstetric patient, for ICU patient, for pediatric patient. This is an important point, and I will take it forward. In our guidelines, we mentioned very clearly that this is a framework of the difficult airway cart. Say, for example, a particular center will be using second generation device as a Procure LMA, some other will be using AMBU LMA, some other are using IGEL. So we have kept it flexible, giving the framework. So we have mentioned that as per the department's requirement or institutional requirement, they can keep it. There will be centers which are neonatal centers. They are doing more neonatal work. Some are doing, say, other children work also. So we have kept that flexibility in the algorithm to take it forward and make it more focused as per their clinical requirement. But you are absolutely right. AIDAA can take it forward to bring examples of the composition of the difficult airway card to suitably different populations. So very good point, sir. We will definitely go ahead and make something very focused on these aspects also. So thank you so much. I think it was an excellent discussion from all the chairpersons, Dr. Jayanti, Dr. Vishli Pandey, Dr. Bala Bhaskar, Dr. Rakhi Goyal, and an excellent session by Jason Doctor, a very important guidelines. And thank you all the participants for so much enthusiastically coming up with the important points. I would request that please go through those guidelines. They are freely available on IJ. We can share it again also. And if you have any queries and comments, do come to the AIDAA leadership and the authors. We will try to put it forward and clarify into our future publications updates, or we can bring it in some way in the update so that we are not missing and keeping our guidelines to the maximum update. So thank you once again. And now we are moving towards another important session, the quiz aspect. And the quiz, again, interesting one. So I will request Dr. Amit to take it forward. Dr. Amit, please. We are sharing a link in the chat. Just log in into the kahoot.in. You can click that link, or you can directly type kahoot.in. And now you will get a pin that will just appear on the screen now. And if you enter the pin in kahoot.it, you will be taken to the Kahoot for today's Quizinar. So pin is just coming. So the pin is 893369. You can scan the code also, or if you're not able to scan it, just type www.kahoot.it. And when you type it, enter the game pin as 893369. So Mithun is with us, Kumar is with us, Fanny is with us, Sagar is with us, Vasika is with us, HTC is with us, Dr. BP is with us. I request if you can enter your first name in full, that will be good, because we'll be giving the award to the top 3 winners, and we'll be also giving a discount coupon for each of the participants who will be attending today's quiz and webinar. I hope everybody has filled the form, because only those who fill the form will be given the email with discount coupon and participation certificate. So please log into www.kahoot.it, and today's pin is on the screen, 893369. Meanwhile, people are joining. I once again request each one of you to register for the National Airway Congress and first International Airway Congress, with having more than 50 international faculty and more than 150 national faculty at Delhi, AIIMS New Delhi, in the month of October.
we can wait for 1 more minute and start, Rakesh?
Yeah, sir, we can wait for another 1 minute, sir. Many people have joined. So maybe another 1 minute. 35 people are there, sir.
Yeah. If anyone has any query or any problem, you can unmute yourself and speak, or you can put it in the chat box. You can even join after starting this game. The pin will be continuously displayed at the bottom. Okay, I think let me start that. No, people are still joining. 39. Yeah. 40. Yeah, we have reached 40 also. Great.
I think some names are really, really lovely. Ketofol is a lovely name. I'm sure the sir or madam will be more enthusiasm to use ketofol in their clinical practice. So popularly known as ketofol. Somebody has put the name as FTP. So we usually conduct faculty development program. I think sir or madam will be very enthusiastic to conduct those programs. Good.
Okay, I'll start. There are a couple of slides which are earlier, which is not part of a quiz program. So that's pediatric airway management, and let's go. So this is Quizinar 7, and we welcome you to AIDAA's Quizinar 7. And again, just to reiterate that AIDAA's National Airway Conference 2026, combined with International Airway Management Meeting 2026, we are doing it at AIIMS New Delhi from 9 to 11th October. On website, that is AIDAA.in, you can easily go and get the information and register. There are a lot of important highlights. And now we have near 40 to 50 confirmed international faculty, 150 national faculty have already confirmed. Okay. Next. So thank you again for the webinar, Dr. Jason, Dr. Vrushali, Dr. Jayanti, Dr. Rakhi, and Dr. Balabhaskar, sir. And I also would like to, at this stage, thank our quiz masters, those who have prepared this quiz, Dr. Kiran Mahendru, Dr. Indu Bala Maurya, Dr. Shilpa Bhatt, and Dr. Shripad Mehendale. Thank you, sir, for your support. So again, there will be images, but concentrate on questions and options. Images may not be exact representations of either questions or the options. Some of the questions are, to make interesting, have some double points, so you can actually score extra. The important point is you need to be correct and fast. So those who give correct answer first or the earlier will gain more point than the one who give correct answer later on. So it is very, very important that you need to be correct and fast. So let's start. During general anesthesia, which factor contribute most to the rapid desaturation during apnea? And your options are this. Decrease closing capacity, higher oxygen cons.
Those who are attending for the first time, just look for the color coding that will be coming to you when you have joined it. So just match with the color coding also.
Yes, most of them got it right. Higher oxygen consumption relative to body weight. Jason, you can also explain and comment in between about what we are doing this in the guideline. Okay.
Sure.
So what is the result? Okay. Rasika and Jeel is leading with FDP, but they are all nearly. Recommended high flow nasal oxygen flow rate for apneic oxygen during intubation in pediatric patient is, and your options are this. I'm not speaking in between, just to give you, idea about, concentrate on this. Most of them are given correct, 1 to 2 liter.
Great.
So I think that is expert consensus,
Yes.
right, Jason?
Yes, that's expert consensus.
Now scoreboard is, Rasika is still leading. Sid is just behind her, and then the G is third. So this is about 2016 guideline, which is not a limitation. Everything else, there are 3 options which are limitation. One thing is not a limitation, and that is what you have to choose. Half of them again right. Clear emphasis was there, and it was there from 2016.
Yes, we
But
had found this SQ to more than 95 even that time.
Yes. The other things were actually not there, and it is part of the 2025 guideline. Let's see what is this. So this was a double point, and Spurti actually did it fast. I think she has jumped to the top place because this was a double point question. This is also a double point question. Appropriate head position for mask ventilation in young child. Very interesting options. Jason.
Yeah. So here again, neutral position, because you don't want too much of soft tissue being included, and shoulder roll, because if you see in children, the occiput is a very large, is usually large than the relative size of the other part of the head. So because of that, you get flexion of the neck, and as a result, there is tongue fall. So when you put a shoulder roll, the tragus comes in line with the anterior line of the shoulder, and neutral position will help. So that is the best combination that is there. Neutral position without a head ring again will lead to flexion. Head extension with shoulder roll again will lead to hyperextension and difficulty in ventilation. And head up position with shoulder roll, again, it nullifies the effect of the shoulder roll. So the best option here is neutral position with shoulder roll.
Okay. Spurti is still leading. Fanny has come up, and Ananya is right behind there. So the leader position has actually changed. So which of the following statement is not true? Relatively easy option. I hope everyone gets it right. Those who have not got it right might be just because they had a issue while pressing the. Jason, yes.
Yeah. So again, the most common causes of laryngospasm are pain-filled stimulus in a light plane of anesthesia and secretions which are causing glottic irritation. So whenever you have either of this, there is adduction of the vocal cords, and that will lead to difficulty in face mask ventilation and difficulty in high peak pressures because of the adduction of the vocal cords even when the supraglottic device is in place. So whenever you have that, and if you don't address it, if you don't recognize it and address it, because of the closed glottis and the efforts at respiration, that can, because of the friability of the pulmonary capillaries, that can cause something called as a negative pressure pulmonary edema and desaturation. That's a problem if you don't recognize it and treat it. And the treatment of choice for laryngospasm is CPAP with 100% oxygen, propofol, and scoline. Scoline is the last resort, but definitely it does not worsen laryngospasm. That is one of the treatment techniques for laryngospasm. So that's again a simpler option.
Okay. Next. And the leaderboard. Spurti is still leading. Ananya has come up. Fanny is still there. Datta and Shefalis are also there. So anyone can come up. There are probably 2 more questions which are double point, and you can go ahead. Again, something which is not true.
Okay, so that was also Macintosh is preferred in older children. Miller blade includes the epiglottis. Yes, correct. Video laryngoscopy, although it may not improve the success rate with intubation, it definitely improves the glottic view across all age groups. Now, I mentioned earlier that the pillow under the head, already the occiput is the largest part of the head, and that leads to flexion of the neck. That is why we advocate putting a shoulder roll and under the shoulder blades, and pillow will just worsen the neck flexion and worsen the laryngoscopy technique. So that is under the head improves. It does not definitely improve. It makes laryngoscopy even worse in infants especially. That is why a shoulder roll is advocated, and there is no pillow that is recommended. So again, that was, I think, an easy question.
Yeah, thank you. Okay. Leaderboard. Ananya has come up. Okay, fine. Because, someone is, when touching the screen, is actually creating a drawing. Okay. Let me press again. Just to, okay. So 12th question, double points. Which statement best reflect recommendation about video laryngoscopy?
I had given that answer in the previous question. That it improves. To see literature, the literature is saying that always video laryngoscopy improves the glottic view, but it need not necessitate and translate into betterment in success with intubation. So although you can see the glottis better, but it is not always easy to pass an endotracheal tube and successful intubation. So that is the most appropriate statement based on literature search that was done by us. It is never recommended to be always the first line technique. You could use whatever you are comfortable with. It is recommended in pediatric difficult airway. That's also a wrong option. And improved glottic view, yes, definitely, but not higher intubation success.
So now Ananya is leading, Datta is behind, and SDC is just behind. Okay. Bimanual primary laryngoscopy. So what is bimanual laryngoscopy? I think Jason has even showed the picture.
Right? So
Jason, yeah.
a lot of people have got it correct, but if the person who is, so this is ideally true for a conventional laryngoscopy as well as a video laryngoscopy, that the person who is using the laryngoscope also gives the burp maneuver or external laryngeal manipulation. So that is the same person does that so that the glottis comes into view. And another person uses an endotracheal tube and passes it through the glottis either by looking at the screen or by looking inside the oral cavity. So that is what, so the person who is doing the laryngoscopy also manipulates the larynx so to get the glottis into view, and another person who passes an endotracheal tube. That is what bimanual laryngoscopy or two-person laryngoscopy is all about.
Okay, next. Scoreboard, Ananya is still leading, Datta is just behind, SDC is there. So it is main position is maintained so far. There are 4 or 5 more questions. Now we are leading towards the difficulty. 2 failed attempt by junior, as saturation is normal with mask ventilation, what to do next? I think people have answered it very rapidly. And I hope this is absolutely correct.
Everybody said it correctly. Very nice. Yeah, so if you see the Delphi recommendations, it says 2 + 1. So the +1 is by the pediatric expert, and that's the most appropriate choice here.
I think everyone was listening to your lecture.
Good.
Ananya, Datta, Spurti. Spurti has come up. She was not there in the first 5. Now she has come back. Maximum supralogic airway attempt recommended. Oh, very rapidly. Less than 10 seconds, everyone answered.
Yeah. Very nice.
Again, very nice. Very nice. Okay.
2 attempts.
Go to the next. Yeah, 2 attempts. Okay, they're still maintaining. Fantastic. Double point question. Preferred emergency airway access in younger children.
Here there are
Jason,
people,
if you want to explain.
here there are people who have still not been very clear. So in pediatrics, the best technique that is recommended is a scalpel bougie tracheostomy. When trained surgical help is available, you continue face mask ventilation attempts, continue apneic oxygenation, try and optimize oxygenation if possible. At the same time, call for trained surgical help. A pediatric ENT specialist or a pediatric surgeon who is trained to do tracheostomy, you proceed with a pediatric tracheostomy as the first line choice. If the surgeon or if the ENT specialist is not available to do a tracheostomy and the child is less than 5 years, then a cricotracheal puncture. So there is a pictorial in the background here, if you can see. The first choice is the tracheostomy. The second choice, if surgical help is not available, is to do a cricotracheal puncture. And if the child is older than 5, between 5 and 12 years, then you do a cricothyroid puncture with using a jet ventilation device.
Okay, leaderboard has slightly changed. That has come up. Now this you need to read probably the guideline.
I had not covered this in my presentation.
Exactly, I know. That is why I said you need to read it in the guideline.
Yes. So, but still there are
So-
people who read it and answered it. 18 people have answered it correctly. The angulation of the cricothyroid membrane. So in children less than 5 years, there are multiple concerns. One is there is a lot of adipose tissue in the neck. Second, the cricoid cartilage is much higher than as they grow up, it moves down towards the adult site. And the third thing is it is angulated. So when you try and puncture the cricothyroid membrane, there is a tendency of the cannula to go cephalad rather than caudad, and rather than ventilating the lungs with the jet ventilation, the jet may escape through the upper airway. So that's why it's recommended to do a cricotracheal puncture rather than a cricothyroid puncture. These are some of the reasons why a cricotracheal puncture is recommended.
Fantastic. Okay. Datta is now maintaining. Ananya is there. Fran is just behind. IE ratio. Again, this was not covered.
No, I had covered it.
And it is part of a guideline.
Only one answer.
Why? Okay, now we're getting some answer.
Oh.
No. This was slightly late, but I think everyone has given answer.
So 1:4 is the ratio, 1 second for inspiration and 4 seconds for expiration. Because if you're using a jet ventilation device, the narrow bore of the jet will cause breath stacking and will cause barotrauma and volutrauma. So if you realize that that jet is used to give inspiration through the cannula or the needle, and the expiration takes place to the upper airway. So although the inspiration is quick in 1 second, you need to give enough time for expiration to occur through the upper airway and maintain patency of the upper airway. Otherwise, there can be volutrauma and barotrauma that can happen. So 1:4 is the correct answer.
Okay. Datta is still leading and Penny is just behind. Dr. Shravanti has come up. Okay, last question. Double points. Let's see. This is also not covered and you need to read the guideline.
I had covered this in the last slide. Both those last two
It
questions.
was there. I didn't remember. Okay. So 19 have.
Which is correct.
Yeah. Yes, Jason. So I think it should be done within this time frame, right, Jason? Yeah.
Yes, correct.
Okay. So number 3 is Dr. Shravanti. Number 2 at 13,000 point is Fanny. And number 1 at 13,856 is Dr. Datta. Congratulations to all 3.
Congratulations.
Dr. Rakesh, are you there?
Yes, sir. Thank you so much, sir.
Let me.
I think wonderful session. So, happy to Dr. Datta, Dr. Fanny, and Dr. Shanti. Will be issuing you the certificate through email that you have entered. You will get a certificate, and all the participants will also get a certificate of participation. We'll be sending within a week on your email. And we also will be sending a coupon code, which you can use for registration to the NAC. If you enter it, you will get automatically discount on the NAC registration. So thank you so much for a wonderful quiz, a wonderful webinar. I'm sure this trend will continue and will come with another interesting webinar 14 days later, again on Tuesday, 7 p.m. And we'll talk about the obstetric guidelines, another important one, where the authors repute will be talking to you on the management of airway in obstetric population. So keep tuned in, and I will request Dr. Amit Shah to give the closing remark. Over to you, sir.
Thank you, Dr. Rakesh. Once again, thank you very much, Dr. Jason, Dr. Balabhaskar sir, Dr. Rakhi, Dr. Vrushali, and Dr. Jayanti for giving us such a valuable inputs. It was a wonderful session, and pediatric airway is one of the most challenging because we don't know, within very short time, the hypoxia starts, the saturation starts dropping. And it was a wonderful insight of guideline as well as various practical tips. Also, I'm extremely thankful to all the delegates, those who have tuned in, participated in discussion, and participated in the our quiz. Thank you very much. Do join us again after 15 days on the Tuesday. We'll again come with the obstetric guideline. And meanwhile, look out for the our Quizinar flyer, as well as please join us at NSC 2026, which is combined with International Airway Management meeting. Thank you so much. Bye and good night. Thank you.
Thank you very much, everyone. Thank you.
Thank you. Good night, sir.
Thank you.
Thank you. Thank you all.
Thank you, sir. Thank you, everyone.